and Dr. Anand Keshav, who is a 6th semester resident at PGI Chandigarh. So over to Dr. Priyanka to start the sessions.
And thank you all for being here with us today. And before we begin, let me assure you all that today's session is going to be very informative about some very practical things that we are going to deal with on day-to-day basis as neurologists and especially as senior residents. So let me introduce the first speaker, Dr. Deepti Vibha ma'am. Ma'am is additional professor, Department of Neurology at AIIMS, New Delhi. Her major achievements she has been recipient of several awards and several honors, especially for best MBBS resident, for best DM resident. Ma'am has published about 65 articles in international index journals and about 30 chapters in books. Her special areas of interest being in stroke, clinical epidemiology, and neuroinfections, among several others. So, which takes us to today's topic. Ma'am will be giving her expert opinion on how to approach a newly diagnosed case of tubercular meningitis. So, handing over to you, ma'am.
Thank you, Priyanka, for that kind introduction. And yes, I'll be speaking on, so I think I can share my slides, yes?
Yes, ma'am. Yes, ma'am. You can start sharing, ma'am.
Okay, so infections is the flavor of the day, and infection is also the flavor of the year. Yes, we know that COVID has rocked the world. Our program AIIMS-PGI update was scheduled in March, and we were almost all set to do this when an infection, a bug came and knocked us all into lonely rooms with a computer in front of us to whom we are speaking to. So it sounds a little strange, but now we are used to it. So I would be talking about how do I approach a newly diagnosed case of tuberculous meningitis, which is the most common neuroinfection. There is a history behind this talk, actually. And if you see the link above, and as I told you, when we were all set to start this conference, we were in a lockdown. And so we started, we thought that, let us continue with the academics. So we went to the set facility of AIIMS, and myself and Dr. Padma took a few classes. So because this presentation was ready, I gave this presentation, but I promise that I'm not going to repeat that presentation. This is going to be a very different one. Of course, we cannot change tuberculous meningitis approach and diagnosis, but the difficult part is probably going to be taken by Dr. Modi. So I'll be dealing with the easier and the more interesting part. And of course, I cannot hold myself back from adding a lot of flavor of COVID with this, and you will see how I go. So we'll be talking about the clinical features, the criteria that we should follow, when should we say that it is not TBM, and when should we suspect something else other than TBM, and how should we follow up these patients. So first things first, listen to your teachers. I mean, I'm not talking about you listening to me and I'm your teacher now, but that I am supposed to listen to my teachers in a generic way, because all the diagnostic criteria that we have been looking at so far, so I take the first one, and this was by my teachers. Dr. Prasad and Dr. Bihari were the co-authors of this paper. So I can, say that, look here, if I listen to my teachers, they can tell me more than what the books would tell me, and this is all written. So we know that when we're talking about tuberculous meningitis, we are talking about a triad of fever, headache, vomiting, altered sensorium, with cranial nerve palsies. It's as simple as that. So there is no big deal in able to diagnose a case of TBM. But however, when you get to the details, so the devil lies in the details. So when we are talking about the clinical criteria, we know how difficult it is to demonstrate an acid-fast bacilli in the cerebral spinal fluid to be able to be 100% sure that this is TBM. So there is a conglomeration of various clinical criteria which make us pretty sure that this could be TBM. Now, first is clinical, of course. So you have headache and neck stiffness with or without seizures and altered sensorium of 2 weeks or more. Now, remember, this was 1994 when the criteria was a little more loose and it could encompass a lot of things. And of course, it included the CSF, which should be pleocytosic, should have CSF pleocytosis, a protein of more than 1 gram per liter, a sugar of less than 2/3 of the corresponding blood sugar. Culture should be negative to exclude pyogenic and fungal meningitis, and a negative cytology for malignant cells, and a CT which could show, basal exudates or hydrocephalus. Now, if you look at this as standalone, you would be able to diagnose fairly well more than 90% of the TBM. So if we look, the criteria were already very much in place in 1994 and were fairly okay. But what changed over a period of time was the time criteria, and I'll show you how. Yeah. So this was the year 1999. Dr. Rashmi Kumar also happens to be my teacher. She is a faculty in King George's Medical College, Lucknow, from where I did my graduation. The unfortunate part of this criteria is that it is only tested for children, not for adults. So this was in pediatrics department. And look here, apart from everything else which looks well in place, apart from the fact that, there would be some things which would be more peculiar to the pediatric population, like extrapyramidal movements and fundal optic atrophy, which were not the highlights in the adult criteria. The cutoff for, being able to diagnose acute and chronic meningitis was a week. And then came the Thwaites paper in Lancet in 2002, which was done in adult patients, which included both HIV and non-HIV, and included 251 patients. And they made a criteria based on the ROC curves, and they put a diagnostic index. The cutoff again goes to around a week. So, more than equal to 6 days versus less than 6 days. And we can see that, apart from this, there's a whole lot of other things as well, like the CSF cells, which were earlier 20. If you remember the 1994 criteria, this is like 900. The partial neutrophil count should be more than 75% to call it acute bacterial meningitis, and less than 75% to call it chronic meningitis. This paper is very close to my heart because my dissertation or my thesis was on validation of this criteria, which was also subsequently published. And what we found in our population was that age was not the determinant. So age turned out to be insignificant here. So as you can see, now we can see that the cutoff is, so the lower you score, the higher the chance that you have TBM. So if you are young, then there is lesser chance, there's higher chance that you have TBM. However, in our population, we found that TBM was spread across all ages, while acute bacterial meningitis was very peculiar to young age. And there was a spurt of meningococcal meningitis in the period in which I was doing my thesis, which fortunately we don't find now. So in this criteria, the only thing that we threw out was the age criteria. And then came the tuberculosis meningitis uniform definition for clinical research. Now, this might look like a very, very detailed one, but if you look at it, it's basically outlining the main criteria. And look here, the cutoff of number of days gets down to 5 days. So we are going down, we are becoming more stringent or tight when it comes to the number of days. And we know that patients can present within a week, within 5 days also, and can still have TBM. And the cell range was made a little less stringent here. Okay. And then you look at other things. But the most important thing here is, and which I'll be focusing on, is to exclude the alternative diagnoses like neurosyphilis, like CNS lymphomas, like pyogenic meningitis, cryptococcal meningitis, viral meningoencephalitis, cerebral malaria, parasitic, and eosinophilic meningitis. So basically, you have to exclude other causes of subacute and chronic meningitis here. Now with that, we come to the COVID case. Yes. So I'll be going to the images first. Now, this is a patient who was COVID positive. I'll get to the details of this case in the next slide. But as you can see that this looks like some hydrocephalus with a VP shunt here, then a VP shunt here, and then somewhere else, and a bad chest X-ray. And the timeline is from early September to late September and then early October. So here we get to the timeline. So this is a 49-year-old male who presented with headache and fever of 1 month and had history of pulmonary tuberculosis in 2011 and has a history of altered sensorium for 1 day. Now, what happens is that now the world has been divided into COVID positive and negative. So irrespective of whatever symptom you have, you're first classified whether you're positive or negative. So unfortunately, this patient came out to be COVID positive. Although clinically, there was nothing else to suggest that he could have had TBM. And so, well, when he was taken to the COVID ward, he underwent a VP shunt. The CSF was done, which showed 10 cells and sugar of 22 mg/%. I really don't have the protein report because, you know, in COVID wards, the paperwork, the papers go into a black hole. You cannot retrieve it. It's very difficult. And so this is all we had. Now the story becomes a little more murky when he was, you know, he was nicely discharged. He improved and he turned COVID negative after that. And then he was discharged, but he came back to us. Now this time he came back to us, he was COVID negative, but he had worsening of symptoms and recurrence of vomiting and seizures. And this is like June. So he underwent a VP shunt in end of June. And then after 2 months, he came with worsening. Now, what would you think? That the shunt has stopped working, of course. So the shunt was revised. He was taken up by neurosurgery directly in early October. And the CSF showed nil cells with a protein of 176 mg/% and a sugar of 56 mg/%. So far, so good. And when the detailed CSF workup was done, he was found to be India-Inc positive. So we had missed this diagnosis for the past 3 months. And it was because, you know, probably in the haste of getting treatment for COVID, this little investigation was probably overlooked. However, as you could see, the chest X-ray went really bad. The patient had vomiting, hypotension, had AKI related to his amphotericin use, and there was a dip in the sensorium, and he expired on 17th October. So we lost this patient, but yes, the lesson we learned that we thought that it could nothing else be but TBM, and we did not look at the India-Inc in the first place. So COVID has led to, you know, some problems when we are looking at classifying the whole world into positive versus negative. We forget the bigger picture. So the diagnostic criteria can help us to rule in but not rule out the diagnosis. That is very important. And whenever the patient is admitted to you again, always start with a clean slate. See what you missed, see what happened, which could have been done otherwise. Okay, so what is the problem? What are the issues in the diagnosis? Now, you know, it is difficult to demonstrate AFB TB PCR is not like COVID RT-PCR. So that's one problem. The symptoms evolve with time and the diagnosis may be difficult in the beginning because, you know, the cells are less. In stage 1 TBM, it could be just thought of as a recent worsened headache. There could be normal imaging. A lot of times radiologists argue, why are you getting the imaging done in this patient? We cannot, you know, rule out a diagnosis of TBM by just doing an imaging. There are several causes of hydrocephalus. And then even if you get something on imaging, it could be a tuberculoma or an NCC or a neurosarcoid or a CNS lupus. So there are varied differentials. So all in all, it's sometimes difficult to pin down a diagnosis of TBM very easily. And although we know that TBM is common, the rare presentations like gyral tuberculosis and tubercular abscess, and even with a correct diagnosis, sometimes patients keep on running fever. And therefore, being sure of the diagnosis can sometimes be a challenge. So this is one example in which we felt it could have been TBM, but it was not TBM. And later on, the patient deteriorated. And there was a flavor of COVID, of course, there. And then when do we clearly think that it is not TBM? Now, the important thing is that we should know that although raised ICP is characterized by a triad of headache and vomiting, fever when present could also be because of inflammation, can also be because of infection. And if it is absent, it is still difficult to rule out the diagnosis of meningitis. You have to do a CSF. So imaging is helpful, but CSF is also very helpful. And we should not treat the patient empirically without ignoring the CSF findings. So this is a standard question. And because my target audience is the DM students, the causes of fever with raised ICP could essentially be anything from meningitis, multiple neurocystic cirrhosis, acute demyelinating diseases, midline space occupying lesions, hyperparathyroidism, thyrotoxicosis, CVT, and dural AVFs. They can all present with raised ICP with the false localizing signs. Now, because I'm discussing about how can we go wrong in the diagnosis of TBM, let me start by my own mistakes. And this was when I was a resident, and a 12-year-old girl came with headache, vomiting, diplopia for 1 month. There was decreased vision for 1 week. On examination, there was bilateral 6-nerve palsy with bilateral papilledema. There was a CT film which showed hydrocephalus, and I was excited. I knew I had to get in this patient, do a CSF, and it will be TBM. So I actually wrote a prescription of ATT on her card, and then I just thought, let me discuss it with my radiologist. And as it turns out, the only negative thing in this patient was that she did not have neck rigidity. So this patient had tectal plate glioma. There was expansion of the brainstem, which was very nicely picked up by the radiologist in the next day neuroradiology conference. But other things which can present similarly could be an intraventricular neurocysticercosis and other brainstem malignancies. So I tried to find out a CT of tectal plate glioma, but in the books, of course, I did not retain that CT with me. I mean, it's bad to keep. It's not a good idea to keep bad memories, but it's ingrained. That CT film is ingrained in my memory. I always look at the brainstem now if there is a swelling in any patient who is presenting with raised ICP. And the closest to CT that you can see would be the T1 film, in which it just shows that it is, kind of iso-intense to hypo-intense with an expansion of the brainstem and with associated hydrocephalus. So sometimes it's very easy to miss it on a CT, but an MRI is good enough to pick a diagnosis. So this is not of that patient, this is from a book. But the next thing is of the patient, and I'll tell you. So this was, of course, what I learned from my mistake. And of course, I did not make the mistake of doing a CSF in this patient. So I first discussed with the radiologist. But this is another patient who was brought to me by my resident. So now this was a 61-year-old lady with headache and vomiting of 3 months, anorexia, generalized constitutional symptoms, which patients always oblige us with. Bukhar hai, haan hai, wazan kam ho raha hai, bilkul kam ho raha hai. So there was papilledema on examination, there was mild lateral rectus palsy, hydrocephalus on examination. CSF was done by my resident in the screening OPD, smartly showed 10 cells, protein of 45 mg%, sugar 40 mg%. So everything consistent. She was started on ATT, no improvement for 1 day, for 1 month. And then because she was not improving, she was still symptomatic, the case was brought to me. And when I looked at the CT, I found that there was something wrong apart from the hydrocephalus. And then we insisted, we got an MRI done. And then it showed that there was multiple, like intraventricular as well as cisternal NCC. Now, if you look at this cut, this was the cis sequence in which we could see the NCC. So multiple intraventricular NCC were there in this patient without apparent chimal neurocysticercosis. So this can very well happen. And this was very nicely amenable to third ventriculostomy. So what are the red flags when you are diagnosing a patient with TBM? What should alert you that this could not be TBM? One is, of course, normal cells. Second is repeated high pressure, can happen very, very commonly especially with cryptococcal meningitis and carcinomatous meningitis. No response to treatment should prompt you about an alternative diagnosis or a multi-drug resistant tuberculosis, or if MRI is not consistent with the clinical diagnosis. And I'll show you one case like that. Again, this case is from the COVID era. So, it's again an interesting one. So 23rd March is a landmark date, it, so on this very day, one patient was admitted to our ward, a 27-year-old male with headache of 1 month, decreased vision in the right eye for 2 weeks, and came with seizures with bilateral papilledema. CSF pressure was 22, nil cells, sugar was 71, protein was 44 on the borderline, our cutoff is 45 here. So India Inc was negative, gram stain negative, ZN negative. Then what happened? There was a lockdown. Everything came to a standstill. So he was empirically started on ATT and steroid. Vision improved, but worsened after 1 month when steroids started tapering. This is the usual story. You see that in a lot of nicely responsive TBMs also, sometimes it does happen that, after you taper steroids, they just show worsening. But repeat imaging was done on April and May. But however, he had complete loss of vision in the right eye with decreased vision in the left eye. And then he underwent a brain biopsy outside because only emergencies were on at AIIMS. So I'll show you the first image. Based on this, there was an impression that he was having gyral tuberculosis with tuberculomas. This is the impression. This is nothing to do with the, the wrong diagnosis versus the right diagnosis. In retrospect, it is very easy to make a diagnosis of TBM or not TBM. But yes, this was what we were thinking of till the time we felt that the patient is not responding as he should. Then this is of April, in which you can see that the lesion has receded. And then in May, the lesion comes back again and involves even the left optic chiasma. Now, this patient had lymphoma, and it was proven by the brain biopsy. So in this patient, we made a right timely diagnosis, despite the fact, that there was this COVID, which was kind of dragging the whole diagnosis and delaying it. So there are many phases of TBM. It could still be TBM. A lot of times we think, when there are persistent fever, when there is drug-induced liver injury, multi-drug resistant tuberculosis, those are the known complications of TBM. So even if the patients are not getting well and smiling at you, after 1 month, you could still be dealing with TBM. Then even if it is TBM, you can deal with other complications, which can be in a very in a very right diagnosis, like hydrocephalus and arachnoiditis. So how do we approach when it gets to treatment? And I think this is the last part of my thing. I'll try to complete it well in time so that I give time for questions and other things. But the broad algorithm is that if you see that the gene expert is negative, which we most commonly get, then unless otherwise proved, you treat it like a sensitive 4-5 drug ATT. And if it is rifampicin sensitive, then you give HRZS or E plus corticosteroids. If it is rifampicin resistant, you do the drug sensitivity testing. If it is additionally isoniazid resistance, you continue MDR regimen. If it is resistant to fluoroquinolones as well, then you give the XDR. And if it is isoniazid sensitive, then you continue MDR plus H. Now coming on to the new thing which I want to share with residents is that when it comes to the Mdr Tb treatment, I'll not go through this study. Yeah, so when it comes to the Mdr Tb treatment, there is an update in the guidelines, which is quite radical in the sense we were always giving aminoglycosides as the mandatory treatment for multi-drug resistant tuberculosis. But the change is now group A, you have to include all the 3 medicines, which includes levofloxacin, bedaquiline, and linezolid. Group B, 1 or both medicines, which includes clofazimine and cycloserine. And group C has the rest of the bag, ethambutol, pyrazinamide, imipenem, amikacin, ethionamide, PAS. There are some nice comments in this update, and you should go through it, which is, especially about the extrapulmonary and tuberculous meningitis. So treatment of TBM meningitis, especially MDR or drug resistant, is best guided by drug sensitivity testing, and it depends upon tuberculosis medicines which cross the blood-brain barrier. So we know that quinolones, ethionamide, cycloserine, terazidone, linezolid, imipenem, they penetrate the CNS well. The seizures are common with meningitis related to imipenem and also with quinolones. So there is a catch, sometimes you cannot give because of this. And high dose isoniazid and pyrazinamide can also reach therapeutic levels in CSF. PAS and ethambutol do not penetrate the CSF. Amikacin and streptomycin, or for that matter, aminoglycosides, only in the presence of meningeal inflammation. And there is little data on CNS penetration of clofazimine, bedaquiline, and delamanid. So all in all, when you are treating patients of MDR TB, and now I'm touching a bit and going on to the zone which Dr. Manish Modi will touch upon, which is upon the MDR TB. There is a bit of paradigm shift in the doses that we have to give in MDR TB patients, and also the regimen. So as you can see, we are giving usually pyrazinamide in the dose of 1000 milligrams, but in a 30 to 35 kg. But in this zone, we should give a higher dose. And if it is more than 70 kg, then we should give 2 grams. So similarly for ethionamide and PAS and isoniazid. So like you can see, the body weight of the high dose is 10 to 15 milligram per kg. And we have trials to show that in drug resistant tuberculosis, the rifampicin drug is not there, I think, in this table, but the earlier trial that I showed in the previous slide had high dose rifampicin. So 15 milligram per kg of rifampicin, if it is used for the first 8 weeks, then it leads to better resolution in drug resistant tuberculosis. Now, some recent lessons which we have learned with tuberculosis TBM in the COVID era is like, this lady who had hydrocephalus and then came back to us just before the pandemic and still had hydrocephalus, but was doing fairly well, was stable. But in September, she came back to us with imbalance while walking and urinary accidents. And this was basically related to her tapering of steroids. She had a history of CA thyroid 5 years back. And we repeated, the CSF almost 6-7 times and did a PET to exclude any alternative cause of deterioration, but we could not find. So this was TBM, but yes, not doing so well as we had expected. Then this is a beautiful case which I would like to share, and this would be my last one, I think. So this patient came to me in December 2018 with disseminated tuberculosis, started on category 180T and had initially DILI with walking difficulties later, which were attributed to this frontal lobe tuberculomas, and no VP shunt was done. And then what happened in May, he had persistent symptoms with walking difficulty. The neurosurgeons refused to do any VP shunt. However, he later went on to have VP shunt despite all resistance. And then in the tele-OPD of September, this patient who was incontinent, unable to walk, unable to talk, I actually thought that it was the son talking to me, and then I realized that this is a patient talking to me himself. I said, and he said that, I'm not now able to walk and I'm able to do my things, I'm able to communicate. And the cheerful voice of the family was worth the effort. So, earlier we used to say, take home messages. Now we are staying at home, so they are stay at home messages. So my stay at home messages are, although the spotlight has shifted from old assassins like, tuberculosis and HIV to new ones like COVID, TBM is still on the prowl. It remains a big killer and one of the rewarding treatable neurological emergencies. The Mdr Tb guidelines have a recent change, so the residents should go through it. Delayed and misdiagnosis of TBM is common, and so is the mimic of TBM being treated as TBM. So the last message, of course, listen to your patients also because they tell you the diagnosis. And thank you for the listening. I think I finished well in time, and